Welcome to Office Hour. It's innovative practices to sustain the family peer workforces. And today we're going to be talking about teaming with mobile crises to connect families to support. I'm Gail Cormier, the project director of NASTAC, the National Family Center of Technical Assistance. Here's our disclaimer, if you could read it. I'll give you a couple of minutes to read. Obviously, we want to definitely thank SAMHSA for this support. Next slide, please. And a little bit of housekeeping. We're going to keep everybody's mics off during the main presentation, but then we're going to go into the breakout rooms where you'll be able to talk in smaller groups. And when we come back, all mics are off, turn on your cameras and ask as many questions. We always use family-driven language. We're trauma responsive. We always are strengths-based. We avoid blaming caregivers. That's one of my favorites and very special to this organization. We're community-driven. We're person first. We're always respectful, non-judgmental, and consistent with our actions. So here's the goals of the series. We want to support family peers to add innovative practices to their toolboxes to best support families. We want to inspire leaders and emerging leaders to adopt innovative practices to sustain their organizations and the family peer workforce. And we want to introduce members of the behavioral health workforce to innovative family support practices in an effort to engage them to integrate family peers onto support teams. Our learning objectives are, at the end of today, we hope that you'll be able to apply basic structure and lessons learned of North Carolina's Enhanced Mobile Crisis, and it's called MORS. We want you to be able to use the data demonstrating the positive impact that MORS family support partners have on the youth and family who participate in the program as evidence of the value of family peer services in your own state and in their state. Describe the challenges family support partners face when working with mobile crisis response and share ideas to improve partnerships between family peer specialists, families, and other team members. And yes, you will be getting these slides. And we send a follow-up letter with the slides to you in about 4 to 7 days. Also, this recording will be posted on our website, so you can hear it again. Next slide. Dana?
Yes. So if everyone could pull out your phone and either go to menti.com and type in that code at the bottom, 66607320, or Gina has put a link in the chat. We're going to ask, how do you support families? You're going to take a Menti poll, and we have a few different choices here. You can pick which one is your primary way that you support families. Do you work on a mobile crisis team? Do you work in a family-run organization, on a wraparound team, in a residential treatment facility, in an ER, in a provider's office, at a state agency, in a school, or in another setting? And if you choose other, if you could please share in the chat what that other setting is, that would be really helpful. We know that family peers and other stakeholders supporting families are doing that in a variety of settings, and it would be great to just have a broad understanding of where everyone is coming in from today. Looks like lots of other. If you don't mind sharing that in the chat. Okay, so we've got Marcia, who runs works at a peer-run youth program. Excellent. Thanks, Marcia. Right now we have about 5 folks employed by a state agency and 5 at a wraparound, 5 on a mobile crisis team, 4 at a family-run org. Tyrea is a caregiver advisor in Maryland. Thank you for sharing. And Cynthia Smith works Family Voices, family to family. Deborah is Grand Family Connections, supporting grandparents. Oh, that's great. We love seeing all these different settings. All right, well, keep typing in the chat and answering that question. We will share the final results with the follow-up slides. It's looking like most of us are working in really diverse other settings with a good chunk in state agencies, wraparound teams, mobile crisis teams, and family-run organizations. Excellent. And you'll get a chance to share, oh, a couple more mobile crisis just came in. You'll get a chance to share that in your breakout rooms too, a little more about your experience later. So are you still seeing Gail's lovely smiling picture on the screen?
We are.
Okay, excellent. All right, so I would love to introduce our speakers. First, we have Gail Rose. She's the program manager of North Carolina Enhanced Mobile Crisis Team, also known as MORS. And she's been working for over 25 years in youth leadership development. But now she's working in direct service at the University of North Carolina, Greensboro, as the program manager for the last 2.5 years. And she's going to tell us a lot more about what that looks like in action. We also have Ashley Roberts with us. She is a family support partner for MORS. In addition to being a mother of 3 children, she has just really devoted her entire life to supporting families from being in the medical field to now becoming a family support partner in July 2023. We're really excited to hear more about Ashley's experience working with the mobile crisis team. Finally, but we have Jessica Hofstetter. She is also a family support partner in the MORS team. After her own experience navigating care and special education with her children, she now helps other families navigate those same and different systems. And now that she has the supports her children need, she understood the importance of helping other parents and caregivers avoid the same difficulties that she did experience. So we'll hear from her as well. And without further ado, I'd love to pass it over to Gail.
Thank you, Dana. Wow, what an honor and a privilege it is to be here today. I had so much fun watching all the different states pop up, as you were saying, just where everyone is from. So thank you for this opportunity. I even recognized a couple names, and that was very exciting. So I'm going to start by just giving a really broad overview of what this program looks like, a little bit of the feedback that we're getting from folks. And then I want to quickly get to the part where we get to hear from Jessica and Ashley, who are actually doing the work in the field, and hear their perspective as well. But a little bit of a level set here to get us started. So you're going to hear me talking about MORS. And those letters stand for Mobile Outreach, Response, Engagement, and Stabilization. We learn very quickly when we're going out and trying to talk about this that those words don't mean a lot to people, especially if you're not in the field of crisis. And it took longer to describe the words than people really wanted to listen. So when we talk in public, we really use enhanced mobile crisis a little more often. If you know mobile crisis, then enhanced mobile crisis kind of makes sense. But for today, you'll hear me calling it MORS. So this particular pilot is a partnership. It's a grant from the North Carolina Department of Health and Human Services, the University of North Carolina Greensboro, and then 4 provider sites across the state. We serve children and youth between the ages of 3 and 21 and their families who have recently experienced some sort of a mental or behavioral crisis. The majority of our referrals do come from the mobile crisis response system across the state. Each of our teams consists of a team lead who I work with consistently to make sure that we're implementing the scope of work to fidelity. In addition to the team lead, there's a clinician, a qualified mental health professional, and a family support partner on the MORS team. The team partners with the youth or the family to help them identify their needs, their strengths, their goals, what they want to strive for. And we're able to do that for up to 8 weeks after the family experiences that crisis. So we're able to encourage them and help connect them to necessary resources and supports for up to 8 weeks. And the MORS support right now is available 7 days a week, 8 a.m. to 11 p.m. Next slide. And for you visual geography type folks, here is the beautiful state of North Carolina. To the west are mountains, and to the east is the ocean. So for me, it's perfect, and I live right in the middle, so I can get to both. But the circled counties are where we are currently providing this program through the pilot. So for Buncombe and Henderson County to the far west, RHA is our provider site. And if you think back to September when you heard about Hurricane Helene, this is the area that was devastated by the hurricane, and they are still struggling to regroup and get things cleaned up. It will be a very long process. Kind of towards the central area, we have Davidson and Cabarrus counties, and Daymark Recovery Services serve that area, and you will hear a lot about Daymark from Jessica and Ashley. A little further to the east, we have Chatham County, and that's served by Monarch. And then to the east, we have Wayne, Wilson, and Lenoir counties, and they are serviced by Easter Seals and Port Health. Next. So a little bit about how the supervision and structure of the program works. As I said, each provider site has a team lead. I meet with that individual once a week, and we talk about successes or challenges. We talk about the scope of work and just make sure that we're implementing it consistently in all 8 counties. A MORS team should have at least one full-time or full-time equivalent in each of the positions that we mentioned, the clinician, the QP, and the family support partner. We did just recently add the qualified professional to the team, so not all sites have that particular role, but at least everyone is looking. And also, we do have several sites that have more than one full-time family support partner, which you'll hear about today from Ashley and Jessica. Currently, the team leads take care of the hiring, and they supervise the entire MORS team, including the family support partners. As these teams grow and we add more counties, we hope to and plan to offer the opportunity for family support partner advancement. Which would mean we would be able to have the family support partners serve as supervisors for the other family support partners. We know that that is best practice, and we definitely want to pursue that as soon as possible. Next. All right, so why have a family support partner? I recognize that I am talking to 61 people that sing in the choir. You all know the importance of having a family support partner. But I did think it might be helpful to see what other folks are saying about why the family support partner has been important for this particular pilot. So one of our team leads, when asked this question, really recognized and focused on the connection that the family support partner has with the family and how that impacts the team. And that quote reads, "I believe the family partner helps us, the team, see a different side of things that we don't realize, whether it's a hard decision of placing their child in an out-of-home placement or the anxiety of the first assessment or when a child runs away. I think she, the family support partner, offers the other perspective for us. The human perspective really makes it real." Family support partners obviously recognize the impact. And a quote from one of them, "I feel like a lot of times the family support partner is the reason why people are getting through the door into MORS, and that's because there is sometimes a mistrust for the system." And when we say getting in the door for MORS, it's important to explain that doesn't mean we accept them as staff into MORS. When we say they get in the door, that means that the family, because they trust the family support partner and the team, are willing to say yes and join the MORS program. Another family support partner pointed out that we let families know that they don't have to walk through this on their own. We're there not to make decisions for them. We are there to offer them choices. Family voice, family choice is an integral part of what we do at MORS. We also spend a lot of time talking to the parents. And so when we asked a parent, what was the most helpful part of MORS? Their response was having someone, a family support partner, to vent to who knew what we were going through. I think that rings so true, and we hear that in lots of different ways. Next slide. And for some of the data folks out there, what are we hearing? What are we seeing? So from July 2023 till December of 2024, We have worked with 345 Moores clients. It is important to understand that some families, some kids come through more than once, and so it was 327 unique individuals. For the first year of this pilot, we were only able to follow up with the families for up to 4 weeks. And that's when we saw so many kids, the 18 that we are represented here, re-entering into Moores shortly after the 4 weeks was over. So we, as the Moores pilot, were able to go to the state and say, we really think that we need a longer time period because we're seeing kids re-enter quickly, and we're not having enough time to really get them connected to the resources that they need. And they listened, which was very encouraging. So now we are able to serve a family for up to 8 weeks. And we believe that those re-entries will greatly decline and hopefully stop now that we have a little longer. Additional input that we get from the families that is really giving us an idea about the impact that we're having on families are these satisfaction surveys. So at the end of a Moores experience at discharge, we ask each family member and adolescent, if they are 12 and older, to give us some feedback. What did you think? How satisfied were you? And in order to have a group to compare that data to, it would give us great information, but we want to know how that compares to families who did not receive Moores. So we have 2 groups. We have families who received mobile crisis in one of those 8 counties from the map that you saw earlier, but for whatever reason, they did not receive Moores. So when they finish their mobile crisis, we wait about 4 to 8 weeks, like with the Moores program, and then we ask them how satisfied they were with the mobile crisis experience. In addition to those folks, we also have 8 counties that we have done some research with, and that they closely line up in population and general services with our 8 Moores counties. And so we also reach out to families in those comparison counties to see, after a mobile crisis, how do they feel about their overall experience. So the next few slides will do some comparisons of that information. So here, we're asking about how satisfied they are, whether they agree, or strongly disagree. My family got as much help as we needed for my child. Obviously, that's the goal. We want to provide the help that's needed. So the column on the left shows you the majority of the folks that are in Moores agree or strongly agree that they received the help that was needed. As you go across, that middle column are the families who live in those 8 counties, but for whatever reason did not receive Moores. And you can see that their satisfaction is slightly less. And then the third column are the folks in those comparison counties. I think it is important, and one of the things we keep in mind when we look at this particular data point is some of the counties across the state, like most states in the country, don't have all the services and supports that a child and a family might need. So I don't know that it's reasonable that we, through Moores, will get the disagree down to 0%. I think there's always going to be some frustration that what my child needs is not available, or we're going to have to travel to get it, and that's not a possibility. But here we can see that there is a difference between the overall satisfaction and getting help between the folks in Moores and the folks who do not receive the Moores 8-week follow-up. Next slide. Another data point, because of mobile crisis in Moores, I, the parent, had someone to talk to about my child when they were in trouble. Again, you see that the Moores participants, very, very few disagree with that. Most of them really truly believe that they had someone to talk to about their child when they were having challenges. And I think I can say thank you, family support partners, because typically they are the ones that have those conversations with the parents. I do think it's encouraging when we think about mobile crisis, big picture, that overall, even families that do not receive Moores do feel like they have somebody to talk to. But we know that it's typically on a very short-term basis, just during the crisis or shortly after the de-escalation. And because of Moores, we have a longer time frame for that family to have someone to talk to. Next slide. because of mobile crisis and more, my child is better at handling daily life. I think that's a goal for all of us who have children. But after a crisis, that can be a particular way to kind of measure how a family's doing and how a child is doing. And so again, you see there's a pretty significant difference between the first column where the family received MORS and the other two columns where they did not. So just that, thinking about that impact on a child and a child being able to handle life just a little bit better is a real encouragement to those of us putting lots of hours into this pilot and seeing that these families really do feel better when they come out the other side. And one more. Because of mobile crisis and more, my child is better able to cope when things go wrong. Again, a pretty significant difference between the families that agree that they do see a change in their children or their child and their ability to cope versus the folks that only experience the mobile crisis response, maybe a quick de-escalation, a little bit of follow-up, but they don't have the time to really impact the child in a big way and their ability to cope. All right, next. And now what I consider probably the best part of the presentation. We got through the nuts and bolts and a little bit of feedback, but look forward to the next section where I'm going to pose a few questions for Ashley and Jessica, and they can tell us what's really happening out there in the field because they are doing this work each and every day. I do want to brag on both of them for just a minute. They are certified family partners. And that is a huge accomplishment. I have learned what that takes to get that completed. And we are working at 4 different sites, as I said earlier, and Ashley and Jessica are the only 2 that have completed their certification for family partner. And so that's huge. I recognize that and wanted to give a quick shout out. So thank you both for being here. I'm going to start by just reading through a few questions. Ashley, I'll ask you to answer this first one first, but you'll both obviously have a chance to answer. So most of us have seen a job description for a family support partner. But what I would like to know is, what does your job really look like in MORS? Maybe a typical day or just your primary tasks as a family support partner for MORS.
So first, let me say thank you, Gail, for that acknowledgement. We really appreciate that. This is great to be here. And it's funny that you say that because I feel like no day is the same. I feel like there's always something unique happening. But it pretty much, is, our referral source. We get our referrals, we contact the families, we engage with the families, kind of based on their needs. We meet them where they are. We go out in person to meet them for our face-to-face visits. We kind of pinpoint the goals and the challenges and we work from there. So normally that is, focusing on, what the goals are, the strengths, the challenges, and finding the resources for them, meeting them where they are. And then, of course, our documentation, our finding resources. We're constantly searching for resources daily. So it's kind of what that looks like on a daily basis.
Fantastic.
Yeah.
Thanks, Ashley. Jessica.
And I would like to thank everybody again for, acknowledging our certifications. It was a very big deal for both of us to obtain those. So my answer is very similar. It is always something new. Some days it looks like we are providing support and validation to a family that is in active crisis, right? And other days we might be assisting families to schedule evaluations and helping them navigate that and accompanying them to make sure that their family and the individual youth is really getting that holistic approach. And it is family driven and it is, person centered. We also often assist families in submitting applications to get connected to those long-term services so that we are decreasing the amount of youth that are going back into active crisis. That's the hope. And supporting facilitation through the navigation of that, because it can get pretty complicated pretty quick. But we really want to make sure that we are ensuring those long-term supports are connected and they are in place for those families every day.
Fantastic. Yeah, that's a lot clearer description than I think most of the job descriptions that I have read. So thank you. Ashley mentioned finding those resources. You both talked about resources, and I want to share that when a question comes up during our team lead meeting, maybe an issue that we're having a hard time finding an answer to, a lot of times we go to Jessica and Ashley to find answers or resources, because we know that's what they're doing pretty much each and every day. All right, Jessica, we'll start with you this time. What impact do you think your role has on the success of the overall Moores pilot?
So I feel like sometimes families can be very hesitant, but when we come in, our role drastically improves that relationship and that rapport building, because we truly can relate to them and to what they're experiencing in the moment, because we've experienced it ourselves. And and there is that validation and that understanding and the empathy and the compassion to what they're currently experiencing. So that allows us to provide all of those things, and to also, support families to identify the possible needs, but also concentrate on their strengths that the family can build upon to obtain all of those supports and services, and really just get the appropriate services and supports in place.
Ashley.
And I agree with Jessica. I think that, excuse me, our role is very important. We're coming in on that personal level rather than that clinical level, and we're able to meet those families, at a better level, and provide from experience. So that's what gets us able to build that rapport with those families, because we've done it from experience. So I think that that's a big factor in it, that it's not just someone coming from a clinical level, but that personal level, that hey, I've went through this, so I know how to navigate the system. Hey, I've done this, so let me show you how to do this. So I think that's a big factor of it.
Yes, absolutely. And I've heard the clinicians laugh and joke that most of the time the families would much rather talk to you all rather than them. And you are able to really build that rapport, which is really fantastic. One of the reasons Dana reached out, I believe, to talk with us is there are not a lot of family support partners working in crisis or mobile crisis. And so I know we've learned a few lessons along the way. But I would like to hear, Ashley, we'll start with you. As a member of the Moores team, what challenges have you experienced as we've learned and grown?
Yeah, so, even though there's tons of resources, there's still that lack of resources, right? So it's still, especially for those families who don't have Medicaid or for those enhanced services. So that's what I've come into, coming into that challenge with, getting those clients intensive in-home or, wraparound services or things like that. So I think that, as far as when someone doesn't have Medicaid, and I don't know that that's like a Moores problem, it's an overall problem, right? So it's not something that Moores can change, but I've come into, that where in housing, just those different resources that are bigger than what we can tackle, right? So I feel like that's one of the biggest challenges is still the lack of resources. So and I think that's going to be an ongoing problem. It's not, so.
Yeah, that's so frustrating when you know exactly what they need and it's just not there.
And you can't grab it, right? Yeah. So
yeah.
Or even the wait list for those services. And, even though we have 8 weeks, some people aren't getting assessments done for 9 months. So it's just so different challenges.
Yeah. Jessica, other challenges that you've seen?
So even we experience some challenges, right? And one of the challenges can be, and this was my experience with my family as well, when you keep hitting that wall, you just feel like you can't get anywhere. And so one of the most it's the biggest challenge, but it's also the most rewarding barrier to support families in overcoming is that their own barrier, and to show them that they have the strength to do this and to really walk through it with them and provide that support. Others can be supporting the family and overcoming those other barriers, right? Those system barriers that are inherent within the system. Like Ashley said, the wait list, the service limitations, the insurance limitations, accessing Medicaid for one applications, that is extremely difficult. And even some possible limited availability of providers, depending on what service you're needing, and just obtaining those appropriate community supports. So very, very similar, I think, in our responses.
Yeah, yeah, definitely heard that from a lot of folks. I am excited that over the last 2 years, the state has put significant money into trying to address some of those. We have new behavioral health urgent cares popping up, and some of the services are expanding, but it's going to take a long time. Long time, but at least the state has recognized, obviously, that that's a challenge, and they're doing what they can to slowly improve that. All right, so the last question for right now, Jessica, you get to start on this one. So without sharing any private or protected information about an individual family, I would love to hear an example of a family situation that you worked with where your role as a family support partner really made a big difference in the outcome for a particular family.
Way back when I was newer, I had this young man who had multiple diagnoses, pretty complex, multiple different behaviors, self-injurious behaviors, very self-harming. And he was failing out of school. He was very isolated, and he had this great support system in his parents, but his parents were lost, right? And we were able to work together to get him connected to, appropriate therapies. We got him connected to peer tutoring in school, and really having that peer mentoring. He began thriving. And so several months after Moore's was over, I'll never forget, his mom sent me this email, and he had graduated high school. He was able to bring his grades back up. He graduated high school, and it was just such a proud moment for the family that they made it through. And I still remember him all the time. And yeah, that is probably my one of my better outcomes. One of them.
Yeah. Anybody else have goosebumps just pop up all over their body out there? Yeah, the stories are really powerful. Thank you, Jessica. Ashley.
Yes, so I had a young boy, and there was a lot of dad was very withdrawn. He didn't want services, he didn't want anyone in his home. He didn't want to talk to the schools, he didn't want to talk to DSS. I mean, he didn't want to talk to anyone. I called and introduced our program. I went out to see him, and he told me from the very first visit, I like your energy. I appreciate your honesty, because I'm not here to paint a pretty picture. I'm not here to make everything perfect, but I'm here to assist the best way I can. School wasn't able to get him to sign releases for school-based therapy, none of that. So I was able to facilitate and get those releases signed. the young man had no services in place. So once we got those releases signed, we were able to get him school-based therapy. We're able to get him an assessment outside of school for additional therapies, just things that dad was shut down on. He didn't want to participate. He didn't want to engage with school or DSS or anything. And then he, he said, you've walked through this with me, and I appreciate that. So that made me feel really good. And in the end, he wasn't getting suspended from school anymore. We had the school-based therapy he was getting weekly, and at the end, dad was even like, is the 8 weeks up? We're done. And I was like, unfortunately, we are. But Mobile Crisis is always here to help. But yeah, so those are like the best impacts when you can have a parent look at you and say, you've walked alongside me and I appreciate it. And I think that's where me and Jessica come in, the important part of us, because at one point we didn't have that. At one point we were those parents that didn't know where the next resource was going to come from. Or you have all of these people throwing these things at you and you're just like, I don't know what that means. Well, what does that mean? What are you handing me to sign? So it's nice to have that person walk alongside you to point you in the direction you need to go. So
That's just fantastic.
yeah.
And I can't help but think about and picture those two stories and a lot of the others that I get to hear as being a part of this. What would have happened if we hadn't been there for these two stories and so many others? And I get goosebumps every time I hear the stories. I'm not sure who I need to talk to, but I think a more appropriate title for both of you would be magicians, because I do think that you work magic with these families, with these parents, and it's an honor to sit back and watch and hear the stories and know how hard you're working. So I think we'll have the opportunity to come back with some more questions later. I have one more slide, but thank you both for sharing, and we'll get back to that. One more quick slide before we move on to some question answers and some breakout groups. But I think it's also really important to acknowledge this has not always been an easy walk. As a pilot, we're trying new things. And so I wanted to share just a little bit about the challenges that we've seen and some of the learning that we've experienced, as I know some of you may have the opportunity to pursue this type of a pilot or a program across the country. So one of the things we learned early on was for MORS to be successful, we needed mobile crisis response to be successful. As I said earlier, most of the referrals come straight from mobile crisis. And there is a significant difference in different counties about how much mobile crisis is utilized and how much it's trusted. So we recognized early on that while we wanted to get out in the community and talk about MORS and what a great experience this is and how it can be life-changing, we couldn't just talk about MORS. We had to talk about mobile crisis, and we had to support mobile crisis and figure out how best to really talk about that in the different counties, because one county could be significantly different than another county across the state. So that was an important challenge and still is an important challenge. The recruiting and hiring, we all know that in the world of mental health and behavioral health, it's very challenging to find folks that want to work in this field. But where we really learned lessons, and I think we'll be able to really apply this as we move forward, is when we were talking about hiring and recruiting the family support partner role. In North Carolina, this is still relatively new position, especially in crisis. And I think that's probably true across the country. So we had to spend some time talking to the human resources folks at the 4 provider sites and explaining just what this family support partner role was all about. It took a while to convince them that no, they did not have to have a master's level in mental health. They had their master's level, it was called lived experience. And so we had to really explain that to the HR folks. They couldn't recruit a family support partner at cliniciansjobs.com or whatever site they used to use to recruit their mental health professionals And so that had to look a little bit differently as well. So a lot of education for the executives who were hiring and supervising these positions, and that's gone really, really well. I didn't know what a battle it would be, but it really was not overly difficult once, especially once they really saw that position in action. Made a big difference. The team leads who do most of the actual interviewing had to think about how they explain the realities of working in the mobile crisis field. Most of the staff that they had worked with and hired in the past came up kind of through the system. They had worked in a mental health facility before and maybe worked in crisis. So we had to get better at explaining what exactly this role was all about, and then trying to prevent any sort of drift in responsibilities. I believe when you work in a team, everybody does everything to the best of their ability. And so there is a part of that we all just want to do what's right for this family, but we do want to capitalize and really focus on what a family support partner brings to this team with their lived experience, with their ability to build relationships and work their magic. Flexible schedule can be a blessing and a curse. Certainly you heard that both Ashley and Jessica have children, and they are still involved in life, and so they have to work around their family life schedule. And sometimes that's a challenge regardless of what job you're working with. And I think one advantage that I have seen in at least some of the provider sites is that also, because you're working with a family who also has a flexible schedule, sometimes that works well. So perhaps once a family support partner, or really anybody on the team, gets their children home and maybe settled, if a family in crisis might need a conversation. And so once things are settled at home, they have the flexibility, because the program does support the families till 11 p.m. They can go out a little bit later and work with that family. So that can be a blessing and a curse, I think, like most of the services that are extended hours and not just a pretty little 9 to 5, which doesn't exist much in the world of crisis. The training, we actually do have, my cohort is a training coordinator, Nagala Rashwan, manages all the training for all of our MOORS staff. And we recognized and continue to recognize what are the gaps for the team members, what do they need to learn, so we can better prepare them to do their job. And responding and dealing with folks in crisis is definitely a challenge when you're going into someone's home or meeting them in the community. There are safety things that we need to make sure that all of our folks are ready to handle. And then burnout and staff turnover. You heard the passion with which Ashley and Jessica talked about their jobs. Excuse me. If we're not careful, that can lead to burnout. It can lead to staff turnover. And I think one of the things that our team leads try to do really well is they do support all of their team members, and they try to make it fun. Jessica and Ashley have 2 supervisors, Courtney and Kevin, who at least they make me laugh. And I can only imagine when you're working with them, and even though the job is incredibly serious, they do keep it lighthearted. They're there for support. They're available anytime. And so we try to make sure that is the norm at all of our provider sites as we roll out this pilot across the state. So those are just some of the challenges. And I think as we proceed and start talking in maybe our breakout groups, we can talk a little bit more about what that might really look like in different areas. So I think that does it for our slides, Dana and Gail. Back to you. My contact information is in the slide. Once you get those, as well as the UNCG link and the state link, if you want to see what else is going on in the state.
Well, thank you. And I believe we're going to go into our breakout rooms right now. Just before we go, I have some comfort agreements that we should all agree on. First, we're always person-centered and we use family-driven language. Let's focus on the strengths and solutions and future opportunities. Let's make space for everybody. This is my favorite one, with the 3 then me philosophy. If you shared, leave room for 3 more people to speak before you say something else, because I'm sure it's important, but we want to make room for everybody. And we're going to save some presenter questions for the Q&A. I see some in the chat already. Deborah, I see your questions. We'll get to them when we all reconvene back after the breakout rooms. So let's go to the breakout rooms. We'll be in there for 20 minutes.
And in that time, you're going to be speaking about what the biggest challenges to implementing family peer integration in mobile crisis teams are in your city or state.
That was a great breakout. I don't know about the other rooms, but our room had a lot of very important things to talk about. I think at this point, we are going to do a Mentimeter.
Yeah.
And if you could do what you did before, there's your mentimeter.com and you type in the code 6660-7320. And if you could answer, what are the biggest challenges to implementing family peer integration with mobile crisis teams in your city or your state? And I think that would be great. Nina also has the link if you need that. We see availability. We see staffing. Funding, always funding, knowledge of services, clinicians trained in assessing, staff turnover, government buy-in, lack of funding. Lots of great points. Knowledge of state resources, needing people of color, services being limited according to the company that you work for, the schedule and pay. Scheduling can be difficult, especially if you have your own family. Limited knowledge about 988. We just had a great training on 988, or a presentation, I should say, last Wednesday. We can send the person who questions about the 988. I'd be happy to send you the slides. Sustainability, reactive approach, training, funding. These are all really, really good thoughts. Well, I think we could go and open it up back to questions. And Dana said she'll send the 988 slides with her follow-up. So let's go to question and answers, and we'll remove my spotlight and see everybody else as well. Hi, everybody. Put your cameras on. Take off your mics. Gail, we had some great activity and questions in our room, and lots of thoughts. One of the big ones that came out even before we talked about being in the separate rooms was, what are some of the ways that family peer specialists play the central role? You get everyone to look at each other when you're working in a crisis team as equals and not a family peer as a subordinate to a clinician. Can you speak a little bit about that? And I see a lot of heads nodding.
Yeah, I think we had, it's a great question, and it's going to be a day-to-day challenge, I think. And Jessica and Ashley can certainly chime in. But what we had the opportunity to do is I started working with the team leads about almost 6 months before we really started the program. So they hadn't hired anybody. We just kept pouring through the scope of work. We have a program in North Carolina called North Carolina Voices Amplified, and they do a lot of the training and technical assistance for family support partners. So they were in my ear constantly, helping me understand the role and the challenges that they had already seen in the field. So in the 6 months that I had to work with the team leads before they ever hired their first clinician or family support partner, we spent a lot of time talking about teamwork, about how everyone is equal, how we had seen the role of the family support partner be impactful in other states and in other scenarios outside of crisis. And so it was a pretty easy sell, but it was a sales pitch to those team leads. When you hire somebody to come in, when you get your team pulled together, this is the expectation of the scope of work. This is the expectation of the pilot, that it takes everybody to be successful. And as soon as they hired their family support partners, it did not take long for them to wholeheartedly buy in to the importance of the role, and how there are definitely times I have heard clinicians and team leads say, I am not important. The important role on this team is the family support partner, because they're seeing the impact, and you heard some of the stories. Jessica, would you add anything to that?
I would. So I feel like during that initial crisis, the family peer specialist, we really get to offer a very unique perspective. And I think that there's a lot of value that's seen in the way that we can provide that support that's related to the family and the youth, and it's with our lived experience, right? And how we can establish that trusting relationship. Have you ever seen the story of the special needs parent who's in the bottom of the hole? Has anybody ever seen that on social media? So think about that story, right? So you see this parent, they're down in a hole, and you see all of these people at the very top, and they're saying, well, just climb up, just climb up. But the parent's stuck, and the parent doesn't know how to climb up. So we get in the hole with him. We get down
Oh,
there,
I
we get
love
in the
that.
hole, and we validate how they're feeling, and we validate how they feel stuck. And we use our lived experience to show them we were in this hole one time too. And this is how we got out of the hole. And this is how we climbed out of the hole to get to those appropriate services and those supports and the providers. And throughout the whole thing, we're affecting a change. So that's just my opinion, but that's what I would say, that's what really connects us. And I think, and then we get to get them over to the clinical staff and really, really wrap them.
Oh, I love that. I'm going to steal the whole piece.
Yeah.
That is wonderful.
Gail, there's a video on that
Thank you.
by Brene Brown. She talks about sympathy versus empathy.
Yes. Yeah.
Sympathy is kind of like, ooh, sorry, yuck, that looks bad on a sandwich. And then the other's empathy, where you get down in the hole.
Yeah.
Beautiful.
I'm learning a lot about empathy this week. There's been a lot of writing lately about that. One thing that kept coming up, and I think everybody here might have this question. This is great for North Carolina, but how do we implement it in other states? Maybe even like rural Vermont. How do we implement this work there? Any words of wisdom? And Jessica or Ashley or Gail, if you have them, or anyone else, let's jump in and think about that.
If it's okay, I can go ahead.
Go
So, my best piece of advice, if somebody was, looking to work in our role in rural Vermont, the first thing I would tell them is that those roles are called parent support providers in Vermont. And I would tell them to contact the Vermont Federation of Families, and that they can help them navigate how they can become certified and how they can work in that role, and overcome those barriers.
Oh, that's great. And that reminds me, if you go to the National Federation of Families website, you will see a map. And on that map, it has all our affiliates. We have state and local affiliates that are part of the National Federation of Families members. And out of there, you can find your closest affiliate, and they have trainings for family peers. A lot of affiliates go right on site, to really train. They do what Gail said that Amplified Families does. Amplified Families was an offshoot of the North Carolina Families United. And those same individuals know how to go into families and really work with families and teach other people how to work with families. They are the ones with the trainings and the techniques. So use your state and local affiliates of the National Federation of Families. And of course, you can always go to our Technical Assistance Center and get it from the national people like us, but it's really great to have them in your own backyard.
Ashley, any other thought from your side?
No, I agree with Jessica. Just, I'm not from Vermont, so I don't have a lot of, I wouldn't know how to navigate those, but I would piggyback off of Jessica for sure.
Yeah, and if you can't, as I said earlier, I am a New England girl and I live in North Carolina, and I can tell you that rural North Carolina is very similar to rural New Hampshire and rural Vermont. So if we can do this, and we do, Gail, have programs in rural North Carolina, we must.
Yes.
Yeah.
Yeah, actually, most of those counties on that map are considered rural by most. Buncombe County has Asheville, Davidson and Cabarrus are relatively close to like Charlotte or Greensboro, but they're still considered rural. And I think from a state perspective, we were very blessed in that the state, our governor, decided to put money into mental health. And so that's why we exist as a MORS program. And so it is systems change. And that we talked in my breakout group, just how frustrating and hard it is to change systems. And I think one of the folks, I won't call her out, from my group said, I'm just annoying. I just stay annoying because that's the only way people will listen when I want to do a big change where it's a system change. So sometimes it does take that annoyance. And I think groups like this, where you can now go back, if you have a state person who might even consider something like this, you've got a little bit of data, and there's a lot more out there in other states that have been doing it, programs like this a lot longer than North Carolina. And so leaning on those folks that are already doing it and saying, look what they're doing and we're not.
Very good advice. We had a great comment from Elizabeth. She said, sometimes people need to decompress before they can have a conversation. A family peer is usually better at recognizing that than a clinician.
That's a great point. And it's something we're actually wrestling with a little bit in MORS, because we, as part of the scope of work, have to make contact with start trying to make contact within 24 hours of the crisis. Well, a lot of times they could use a little bit more space, and they might say yes if we could give them a little more time. So that's a part of our scope of work that we're actually looking at, and can we give them, if they want it, a little bit of a break, and we'll come back in 2 days and maybe 3 days and say, hey, what do you think about this MORS thing? I think it might be helpful. But when you have to ask them 24 hours after the crisis, I think we're getting some no's from families that might be yeses if we could wait a little longer. Because that's a really great point, Elizabeth.
Do we have any questions that weren't resolved in the breakout groups? Does anyone want to take off their mic and ask the team? Brianna.
Thank you. I'm just curious, in addition to the initial curriculum for MORS, is there any additional training or likely probably CEs, or any other trainings you encourage them to take?
Yeah, no, that's a great question. We, as part of the grant, have 2 positions. My position is program manager, and there's also a training coordinator. And that is her whole job, is to talk to the team leads, talk to the staff that are doing MORS, and find out what do you need to learn. And we use the Relias learning platform. It's one that's pretty well known across the country, and they have, I think, almost 300 trainings on behavioral and mental health that are available. So any more staff person has access to the Relias learning platform, so they can pick a topic and go look. And some of them do have CEUs, some of them do not. So we are really focused on the training aspect and trying to make sure we are equipping all the more staff to the best of our abilities in well beyond just what the scope of work says MORS is. So great question. Thank you.
Good. Thank you for that. That's
Elizabeth.
Hi. I've met some of you before. My name is Elizabeth Reddick. I live in Washington, D.C. I guess my question is, and we discussed this a little bit in the breakout room, is I'm trying to get our local jurisdiction to recognize the National Federation of Families version of the family peer support, because right now we don't have anything for families in DC. All we have is DBH's certified peer, and it used to be different tracks you could go on, but now it's just that. For the entire district, we only have like 157 peers certified. That's it. We have way more jobs than we can fill, but we're not getting people certified fast enough. And a lot of times the person that they're looking for is not a clinical person. It's a person that actually can, help go to court with you or help you, figure out like, just the general community stuff, right? So there's a lot of disconnect. So what advice could you give about setting me in the right direction for that? I'm already connected to Total Family Care Coalition, which is the only one affiliate in DC. So I'm already
talking, Elizabeth, are you talking about Gail Adler?
Yes, I'm already in community with her. But what I'm trying to say is that I'm like a lone ranger on this. And I know how to do it, but I'm trying to make sure I do it the right way. So it's like, how do I push for it? I'm like to the point of writing the legislation myself. But like I'm being dead serious.
I hear you. I think that the family peers in the Washington, D.C. area and the DMV are very, very, they are some of the most ambitious and really members. So I appreciate that, Elizabeth. Thank you, and keep up the good work. Gail Advent is definitely someone who you can connect to, but you said you already do. But really, if you'd like to go onto our website, and I see Gina put that in the chat, and fill out a technical assistance question, I will have Lachelle and or myself meet with you, and we can kind of break it out in detail, and we can help.
Thank you.
Well, that was a wonderful presentation, and I really, really want to thank everyone for being here, and particularly Ashley and Jessica and Gail. Thank you so much.
Thank you for having me.
We totally appreciate it. Next month, we have a very important person coming in. Her name is Tara Larson, and it sounds like everybody's from North Carolina. Tara was actually the Medicaid director in the state of North Carolina, and she has her own organization. She talks all about billing, how to bill for things like this. And I know there was a question here that said, how do you bill? How can we better tie clinical people on our team with peer family support when servicing the clients separately is mandatory due to billing? Well, guess what? Tara is going to be able to really answer that question for you. So in the chat, you can register. It's the same time every month this is Tuesdays at 3 o'clock for an hour and a half. So you will be able to see us same time, same channel. Meanwhile, I want to thank everybody, and here is our contact information if you need it, and also Gail's contact information is attached here. Now I have to do my little begging presentation, and this is really important. If you could either use the QR code or the link in the chat, if you could go and fill out that survey and let Samson know how we're doing and tell them what you think we could do to improve or what we should keep on doing or what you need more of, we'd be happy of it. I will keep this chat up, this Zoom up for about 5 minutes because it's so easy. If you just personally leave the chat on your own, it takes you right into the survey. And then when you finish the survey, it takes you right into a certificate. So that's the easiest way to do it. But if you would like, feel free to fill out this, to follow the link and go that way, or take a picture of the QR and go that way. But in any case, please, please, please fill out that survey. And thank you and have a great rest of the week.